Let me invite Dr. Leena to present her talk on the preoperative evaluation and intraoperative pharmacological interventions. Dr. Leena Mariyam Varghese is an associate professor with us at Believers Church Medical College. She has trained at Yenapoa Medical College and did her anterior segment fellowship at Giridhar Eye Institute.
Good morning, all. At the outset, I'd like to thank Dr. Satish for giving me this opportunity. I also appreciate the efforts of the organizing committee in conducting this wonderful conference. My topic is preoperative evaluation and intraoperative pharmacological interventions in small pupil cataract surgery. As a cataract surgeon, we are very happy when we see this pupil, but this makes us sad and a little bit tensed. So I'd be going through these contents. So small pupil, just like how Sir said, there are studies that have shown that in South India, there's about 44% of people who come with pupil dilatation less than 5 mm. 63% of the people on tamsulosin have IFIS during surgery. The etiology of small pupil, as you all know, is ocular, surgical. There are systemic causes, most commonly drugs, especially tamsulosin. Why is small pupil such a big problem? It limits the field of surgery. That is, if there's a decrease in 1 millimeter of the pupil size, it would actually decrease around 10.2 millimeter square of the anterior chamber area. So the rhexis that we make is very small. So there is a chance of rhexis extension and PC tear if you try to take out a large nucleus through the small pupil. There's chance of damage to the iris sphincter causing iris sphincter tear, bleeding, iris prolapse. Since the space is less, there's more chance of endothelial damage when you do a phaco. If the rhexis is not proper, you can have an asymmetric IOL placement and associated lens subluxation. So as a whole, the complications are much more when you have a small pupil. So coming to the preoperative evaluation, why is it important? Because we need to prepare ourselves for the surgery. So you need to take a detailed history, know whether the patient has any recurrent uveitis, whether the patient is on any anti-glaucoma medication like pilocarpine, ask his systemic illness, history of drug intake. Make sure that you dilate the patient with the dilating drops, wait for at least 30 minutes and then only measure the pupil dilatation. So on examination, you should have a good look at the corneal endothelium, look for any gut tear, if possible do a specular microscopy, and if the endothelial cell count is less, you need to use the soft shell technique. If there are any signs of uveitis, and presence of posterior synecdoche, you need to break the synecdoche during the surgery and there is chance of a floppy iris. In presence of pseudo-exfoliation, you should keep a CTR, anterior vitrectomy, and an iris IOL ready in case you need any of those. Now, if the cataract is very dense, you will need a large rhexis, which may be difficult in a small pupil. Coming to the pharmacological management. What is the advantage of pharmacological management? It is less costlier. There are no sphincter tests. Hence, there is less incidence of floppy iris and iris prolapse, decreased surgical time, and no learning curve at all. So coming to the preoperative management, we all use topical NSAIDs. Topical atropine can be used, home atropine, and intraoperatively you can use intracameral mydriatics and viscomydriasis. Topical NSAIDs, we use TID or QID 3 to 5 days before surgery. It blocks the cyclooxygenase and inhibits prostaglandin-induced meiosis, hence maintaining the pupil dilatation during surgery. Atropine, there are different ways atropine has been used. There's a study that has used atropine twice daily for 10 days before surgery, and they have found that the iris size is maintained beyond 4 millimeters during surgery. No pupil expanding devices were required, and there was no post-op glare for more than 3 days. There are studies that have used 3 times daily for 3 days before surgery, and atropine 1% 40 and 20 minutes prior to surgery have shown to reduce IFIS incidence. The intracameral agents are rapid, they act very fast, they are predictable and have sustained dilatation during surgery. It acts directly on the dilator pupillae. It is preservative free and bisulfite free, hence it is safe for the endothelium. There is less systemic absorption than topical. So these are the intracameral agents, basically intracameral epinephrine along with its combinations. Intracameral epinephrine has to be used in diluted form. You need to dilute it in the ratio 1:3 so that the dilution becomes 1 in 4,000. Since it is preservative and bisulfite free, it is safe for the endothelium and doesn't cause any macular edema. It dilates within around 20 to 30 seconds and it maintains intraoperative pupillary dilatation. This epinephrine can also be used along with the irrigating solution where you combine 0.5 cc of the epinephrine with 1 in 1000 adrenaline mixed with 500 cc balanced salt solution. This prepared mixture has to be used within 6 hours, otherwise the effectivity decreases. This maintains the mydriasis during surgery. There is no rise in BP or heart rate noted. Combinations of epinephrine can be combined with NSAIDs or lidocaine to increase the efficiency. 1% phenylephrine and ketorolac prevent intraop meiosis, and this intracamerally can be administered along with the irrigating solution also. Intracameral phenokin is a combination of phenylephrine, tropicamide and lidocaine. It helps in mydriasis as well as gives ocular analgesia. So this is intracameral phenokin being used after nucleus has been delivered. The pupil became small, and you can see as soon as the phenokin is injected into the anterior chamber, the pupil dilates fast. Viscomydriasis, all types of viscoelastic can cause minimal mydriasis. Most effective is highly viscous cohesive OVD like Helon 5. And indications are they help in deepening the anterior chamber, it enlarges the small pupils and helps in dissecting adhesions and can be used during IOL implantation. So here you can see viscomydriasis. In a small pupil, most important is to get an adequately sized rhexis. So what you can do is you can inject viscoelastic near the pupillary margin and make a rhexis to around 2 to 3 clock hours. Again inject viscoelastic like that, go around 360 degrees and make a adequately sized rhexis. So the take home message would be pharmacological interventions have limited role when the pupil size is less than 4 millimeters. It helps in maintaining whatever obtained mydriasis that we have. There are lesser complications like IFIS. Intracameral is more rapid and effective during surgery, especially at any step. And if an adequate size rhexis cannot be obtained, always use other surgical interventions. My references, acknowledgements. Thank you.
Thank you, Leena, for that wonderful, crisp presentation on this big topic.